I'm going to do a video on the anesthesia log and walk you through that and show you how to fill that out. So I'm going to share my screen here. All right, I'm going to also show you, you know how when you first log in to WinOMS, it'll have that window that opens and it shows you like to pick from, which office, and then you clock in. And then when you hit the scheduler button, it'll refresh to whatever office you picked originally. If you, for instance, select the wrong office, you don't have to X out and log back in. You can just come to this main screen and you'll just change your windows and then hit OK. And that'll change your office that you're in. So when you go to your schedule and refresh, it'll be the one that you're in. So I'm going to pull up my account and I will walk you through. Again, this is my account. This isn't patient protected information. This is mine. So we'll add a new one. The computer's going to yell at me because I don't have a monitor connected. Okay, so once we're in, our first most important thing once we get a patient into the chair is to hit start. So you cannot hit start until your monitor is on. If you hit start before your monitor is turned on, it creates like a locked out kind of system where the monitor and our anesthesia log on the computer will no longer pair. You have to close it out and restart it. So you never want to enter all this information and then remember and try to hit start and your monitor not be on. The other reason that hitting start when they first get into the chair is so important is because this time clock here also is going to relate to our billing. So if we pull up my treatment plan, this is an old code from back in the day, so typically you'll never see this again. Everything goes by 15-minute increments. The new code is D9222, and it's the first 15 minutes of anesthesia, and then you'll see another 15, another 15, another 15. But either way, this is a total of an hour. We need to run anesthesia for 5 minutes less than what we're billing for. That is the total time the patient's going to be in the room under anesthesia, or the anesthesia process, beginning anesthesia, monitoring them throughout surgery, and then the anesthesia recovery process. So that's the total time. If we went over, like let's say we billed for 55 minutes, and then something happened in surgery where the tooth was just more difficult to get out, and it ended up taking an hour and 15 minutes, and we only billed for an hour. We don't go back and then say, okay, well, here's more money. Like the patient owes us more money now. We won't do that. So all we do is we bill for the time that we are expected to be in that room. So like I said, this needs to be 5 minutes less than what we are billing for. It has to at least be that. It can exceed that, but it has to be at minimum that. So when that time clock says 55, or our treatment plan says an hour, and our time clock says 55 minutes, you can stop it. If we're billing for 45 minutes, once it gets to 40, you can stop it. If we're billing for 30 minutes and it gets to 25, we can stop it. But that time clock is going to be the entire time once they get in, once we do anesthesia and while they're recovering. If they're still in the room, you can certainly stop the record and the patient's still going to be in the chair and we're just monitoring them while we're cleaning and getting everything, I guess, flipped and cleaned. There's no harm in it still running, but it's certainly, sorry, I keep clicking on this to make sure. It kicked me out earlier, so I just want to make sure that my my window doesn't get kicked out. But you can leave it on them. But again, once we have that time, you can disconnect them and then really just start bringing the parent back, going over instruction. But it needs to at least be that. So typically they'll sit in the chair, I'll hit start, and then I'll go to here and click, and a little drop down will come down and it'll be like a time clock, and you can just click that time clock. That way you get the current time instead of having to type it in. All right, we asked them who came with them, mother, father, spouse, son, daughter. It'll never be none. because they're under IV sedation. They can also they can't call an Uber for somebody to come get them, and they can't call a taxi. They need to have somebody who is responsible for them the entire day. If they are under the age of 18, it has to be a legal guardian. Mom, dad, if it's grandma, she needs to be a court-ordered or court-appointed guardian. If it is a stepdad or a stepmom, then I don't care if they've been there since the day they were born. You either need to have adopted them or show that you have legal guardianship. Height in centimeters, weight in pounds, NPO. PO means by mouth, so NPO is nothing by mouth. So we ask them, when was the last time you had something to eat or drink? And NPO, we'll just put 8. Ask them if they wear contacts. If they wear contacts, if they're dailies, I ask them to throw them into the trash can. If they are monthlies, I'll get the little tooth containers that we get baby teeth back in. I'll fill it with saline solution, have them put them into that, and then I tape around it with the IV tape, because if not, the lid will pop off. And then I ask them if it's specific to which eye, and then I'll write L or R on the top of the Sharpie. ASA is our health score. If you're healthy, you're an ASA class 1. If you're a smoker or obese, you're automatically a class 2 if you have a systemic disease that's controlled. So high blood pressure, but you take blood pressure medication, so you don't have high blood pressure currently, you're a class 2. Class 3, uncontrolled, or diabetes. So high blood pressure, but you don't take medication and you still have high blood pressure right now, class 3. Class 4 is going to be major systemic disease. So kidney disease, liver disease, and then class 5 and 6 is going to be end stage and morbidity, but we don't have those. We will typically only see class 1 and class 2. Class 3 is going to be a case by case, and class 4 really just depends, truthfully. Class 3 and class 4 is going to be case by case. So surgeon, obviously. Assistant 1 is who's doing the surgery. Assistant 2 is who is doing anesthesia. You can fill out 3 and 4 if that's somebody that's in the room that's floating. Pre-op, blood pressure, pulse, oxygen saturation, respiration. We don't do temperature, and CO2. Mallampati score, you can Google Mallampati score. We typically in our office will only do a class 1 or class 2, possibly maybe a class 3 under light sedation, really just depends. Class 4, typically not. Comments, pre-op comments. So this is going to be where you're going to write their last menstrual cycle. If it's a patient who we told them they need to stop smoking marijuana 1 week prior, I'll ask them, and then I'll say, patient denies marijuana use for 1 week. Surgery info, our IV site, hand is typically going to be for Dr. Maharaj. Antecubital is usually where Dr. Pham will do it, so we'll unmark hand. Right or left, you need to change that. Like, let's say we can't get an IV in the right arm, so you'll need to change it to left. Those type. So Dr. Pham is typically always going to be a catheter size 24, so we'll fill that in. Dr. Maharaj is going to typically always use a butterfly. Our system, for some reason, will not let us click here now. I don't know why, but for whatever reason, you have to type or click catheter, and then you can type 21 gauge butterfly, and then you'll unclick catheter. So anesthesia start, like we said, is when we hit start here, which is when they sit down in the chair initially and we get started. Anesthesia end is when we hit stop. So when our time clock reaches the allotted time. Surgery start for Dr. Pham is when he gives his first injection of local anesthesia. Sorry, I keep going back to here because I don't want it to kick me out. So then surgery start, first injection of local anesthesia. For Dr. Maharaj, it's going to be 10 minutes after anesthesia start. Surgery end is going to be when Dr. Pham places his last stitch. For Dr. Maharaj, surgery end is going to be 10 minutes prior to anesthesia end. Dr. Maharaj wants us more so focused on the patient, their breathing, monitoring their airway, monitoring their IV site, rather than focusing on our chart. because we can go back in and we can enter our charting information. So then I think that's it for this window. Surgery vitals, we take EKG snapshots every 15 minutes. Drugs, oh, I heard it yell at me. Stay in the call. Okay, perfect. So drugs, we are going to click and drag and drop, and we will fill in our drugs. So you can use these up and down arrows, or you can type. The only one you cannot type is going to, or use the arrows, is going to be ketamine, because it goes up by 0.5, and we only give ketamine in 0.1 or 0.25 usually for Dr. Maharaj. We will fill in our drugs. We'll fill in our local anesthesia. You can add, not everything will be in here. So like if we give Marcaine, we'll need to add Marcaine into our log. So you just hit OK, and then that will add it in here. You can also add like emergency drugs like naloxone. So the only emergency medication we have underneath here is succinylcholine, which is a muscle relaxer. Everything else is going to be under IV sedation medications. The one thing that will trip people up consistently is sublimase citrate is fentanyl. So just know that is your other name for fentanyl. And then post-op, our blood pressure when surgery, or sorry, not our blood pressure, our vitals when surgery end will go here. When we go and hit stop and we get ready to completely disconnect our patient, that will be these set of vitals. I always go through in the beginning of this log and just mark all of this, because I know we'll never dismiss a patient unless these are the conditions. We would never dismiss somebody who is having any sort of respiratory trouble or isn't responsive. So I just always mark no complications. They're responsive. They left without assistance. We may need to change this one. Sometimes they leave it in a wheelchair, but typically it's without assistance. Their escort, we know who their escort's going to be from the beginning. Instructions are given to either parent or just escort or guardian. We give verbal instructions, we give written instructions, comments. We write what we discard in drugs. So discard, and then you'll type like 2 of 5 fentanyl, and then 2 of 5 Versed, or it might be 1 of 5 Versed. And then we can type any additional information here as well. Whoever hits stop and disconnects the patient, their name will go here, and then you can do the time as well. And then, are you having double vision? No. Are you in pain? No. Are you feeling nauseated? No. And then when we go to disconnect someone, this is the most important part. We'll take one last EKG snapshot, and then we'll hit stop. You do not turn your monitor off yet. You're going to hit stop, and you're going to hit OK. Now I need to wait until this window closes. Now that that window has completely closed, now I can turn my monitor off. Let's stop presenting. This is more so for Chantilly. Chantilly's computers are a lot slower. So sometimes it takes a moment for that screen to completely close. If you turn off your monitor and your computer times out trying to close that monitor or close that log, that anesthesia log, and save it, you will lose all of your information. In the event that, let's say, our computers, we have a power outage or something with our monitor or computer goes down, you will need to print out the patient record. So you have what's called a trend. So if you push the trend button on your monitor, you can use that dial. You'll see, this is why it's important for your monitors to always have the correct date and time. So whenever you have time change, or maybe we get a new monitor, you need to make sure you need to go into the system on our physical vital machine monitor and change that date. But if you need to print it, a physical copy, and you don't have that computer log, that anesthesia log, you will hit the trend button on the monitor, use that little dial to scroll through, because you can't just hit trend and hit print. It will only print the portion that is currently on that monitor screen. So you'll print this, you'll scroll, it'll move over time, you hit print again, and keep doing that. And then if it's in the middle of surgery, you can print some EKG strips, but you'll just need a printed record to be able to save into the patient's chart, and then we can hand chart everything. Or if the system comes back up, you can go in and create a anesthesia log and at least put all your times and stuff back in. You won't have that vital tracking from the monitor, but you will have it printed out physically. So you can make at least the chart itself that has all your information and all your drug logs and stuff like that. And then just make a note in that account. I would put a note on the anesthesia log itself, and then also like maybe go on their contact note and on the surgery note and just say, monitor stopped working mid-surgery, created an anesthesia log with drugs and pre and post-op information, printed vitals from monitor, and then have that scanned into the chart. I think that is it. The way I ask questions when I'm sitting a patient into the chair is I sit them down and I kind of have this spiel every single time. So I ask them who came with them today, and then when was the last time you had something to eat or drink. That's important because if you just say, when was the last time you had something to drink? They could have had, you know, an entire water bottle before they came in here. So always say, when was the last time you had something to eat or drink? And then I ask any illegal drugs or alcohol in the last 2 days. If somebody smokes marijuana, that will affect their anesthesia. Also, if they have drank alcohol in the last 2 days, that will affect their anesthesia. And then I ask if it's a female, when was your last menstrual cycle? And then when they tell me if it's been over 2 weeks, I ask them if there's any chance that they can be pregnant, because the drugs that we give would be at risk to a fetus. So then we just get them connected. We ask them, you know, height, weight. I think I went over that. We ask them if they have contacts in. And then as we're getting them connected, we ask them if they have any questions. And then I just start to let them know what the process is. So I ask if they've had anesthesia before. If they have had anesthesia before, I ask them where it was. If it was in the hospital, it's going to be different than what it is here. So if they say no, I just say, okay, like it's not going to be like in the movies where you have a mask over your nose and you count down from 10 and you're asleep very quickly. Here, you're going to be breathing on your own, so you're not going to have a tube down your throat. So we're going to go nice and slow. It's kind of like when you fall asleep at night. You don't know exactly when you fall asleep. You just kind of do. And then I let them know that if you're awake, it's because you're supposed to be. Because what we do is a moderate to deep sedation. So if this patient starts to wake up at the end when we're stitching, which is what we want them to do. I mean, we're done at that point. Or let's say this is somebody who has sleep apnea or they're snoring. So for a brief moment in that surgery, maybe for safety, we're going a little bit lighter sedation. And let's say now their eyes open. The way I explain IV sedation, moderate sedation, and deep sedation, this is kind of like being blackout drunk. So when you see your friends out at the bar, if they're blackout drunk, then these people are talking, they're communicating with you, but they have no idea what happened the next morning. So that's kind of what the drugs do that we give. These patients, they can still respond to you. You know, you tap them and open your mouth, open your mouth. It might take a while for them to respond, but eventually these people will respond to you. Or they may be completely eyes closed, asleep. But you know, you can say, hey, take a deep breath through your nose. And then eventually they start breathing through their nose more. So I have just found that when I let them know if you are awake, it's because you're supposed to be, then usually their transition in surgery is a lot better, because we don't want somebody, you know, when we're stitching up, their eyes to open and then be like, I'm awake, I'm awake, I'm awake, I'm awake. And we're like, yeah, we know. Because that way you can't really reason with them. Same way you can't reason with somebody who is under the influence. You know, if you see somebody out at the bar and they're being confrontational or they're being emotional, they're crying, there's no real reasoning with this person at that point. So same way, I just let them know, like, hey, you may wake up at the end when we're getting your mouth kind of cleaned up and placing some stitches. If you're awake, it's because you're supposed to be. If you're awake, most likely you're done and you're ready to go home. And I just tell them, like, you may wake up, you might feel our fingers like moving around in there, but you'll be numb, so you won't feel anything. And then we let them know when you wake up, you're not going to be able to feel your tongue, your cheeks, your lip, or your chin. Everything is going to be numb, and you'll have some gauze in your mouth that you're biting down on to stop the bleeding. So we want you to try and not talk. And then I explain laughing gas. It's not going to put you to sleep. It's just going to relax you, make you feel kind of like nice and tingly, takes away some nerves. And then I say that we'll start an IV. We'll give them medication through the IV line, and they'll slowly go to sleep. And then to you, it's going to feel like 5 minutes, like you just blinked your eyes, but really you'll wake up and you'll be done. So that is it for our anesthesia video.